Hi, this is Brian Kim. I'm going to share with you this case of a patient who had cataract surgery. He had really these very large excursions with his breathing, so I felt like I was doing cataract surgery on a boat. And I was actually feeling a little bit dizzy. And so, I write here, I need Dramamine. And so you'll see how I get through this case, trying to control the eye the best I can, despite all of this movement. So you can see this patient with the movement with his breathing. I'm using a cotton tip to steady the eye, and then using the corneal marker, which will help me to center and size my rhexis. And then I'm making my incisions, first on the right side and then the left side, making sure I'm flat to the iris plane to create a nice horizontal corneal shelf, which will allow me to achieve a self-sealing incision. I'm going to inject some intracameral lidocaine and then some dispersive viscoelastic to fill the anterior chamber and to coat the corneal endothelium. Using the cannula to hold the eye, I'm able to control the eye, turn it away from me, and this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then enter, and then flatten out again. By doing it that way, you get a nice straight incision, internal incision. I'm injecting some more dispersive viscoelastic before I come out. Turn the teeth of the rhexis forceps sideways, and then go in. So again, his eyes moving quite a bit. I'm just trying to be careful as I do this rhexis. I puncture, and then I'm just teasing it with the teeth closed to create a little flap on the right side. I'm pulling it and then grabbing the edge and then going around circumferentially, trying to do the best I can to follow the corneal mark that I made before. So, this patient may have, I don't know, I don't remember his body habitus or his other medical conditions, if he has sleep apnea or some other issue. But he has quite a bit of a big excursion when he's breathing. So I finish the rhexis, come out, and then burp the incision. And this is the capsular fornix hydrodissection technique. I place the cannula out underneath the rhexis edge contra-incisionally, point the tip down into the capsular fornix, get a nice fluid wave, decompress on the left side, and then point the tip down on the right side, and the lens begins to spin. So irrigate the cornea, making sure the sleeve is the appropriate length. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. And remove the surface epinuclear material. I place the chopper underneath the rhexis edge, point the phaco tip vertically subincisionally, bring both instruments together, crushing the lens in half. That's the double chop. Place the chopper around the contralateral equator, pulling essentially towards the phaco tip, crushing the right heminucleus. That's the cross chop. Getting the chopper around that first quadrant and using a little bit of vacuum, crushing the lens between the chopper and the phaco tip, and then emulsifying that first quadrant. Getting around the second quadrant with the chopper, pulling it centrally towards the phaco tip very carefully, crushing it, separating it, and then lifting it up with a little bit of vacuum, crushing it, and emulsifying the lens pieces. Just rotating the lens a little bit, getting easier access to that last piece of the second quadrant, lifting it up with vacuum and emulsifying it. Rotating the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco-tip. The phaco-tip is in a deep position. It bisects the second heminucleus, placing the chopper around the third quadrant there. It didn't really do anything there, and I just use a little vacuum. It pops the lens up. It's tilted a little bit. Place the chopper around the lens piece, sandwiching it and crushing it. Using some vacuum to position the lens piece and then crushing the lens pieces. Now that I have two instruments in the eye, it's a little bit easier to control those excursions that I had before. And so before you get two instruments in, it's a little bit more of a challenge. But with the two instruments in, it seems like the excursions are less. I place the chopper around the fourth quadrant, crushing it between the chopper and the phaco-tip, and then using a little bit of vacuum, positioning that piece, crushing it and sandwiching it, and then emulsifying the lens pieces. I would say that's a moderate lens density, about 2+. Once all the endonucleus is removed, I grab the anterior aspect of the epinucleus and it starts to tumble out of the bag. I take the chopper out, push BSS in, take the phaco-tip out, and then go in with the INA handpiece. I always start subincisionally, going up against the anterior cortical material, using the vacuum to get occlusion, and then sweep side to side. Going around circumferentially, removing the cortical material again from anterior to posterior. Switch to the polish mode and polish underneath the rexus edge of any cortical material and lens epithelial cells. This polymer tip is really great. It just gives me a lot of confidence. I'm able to polish aggressively with very little fear that it's going to damage the capsule. Because the tip is disposable, I don't have to worry about small burrs or shards on the edge of the tip to cause any damage. So I use the cannula to go into the subincisional capsular fornix while irrigation is going, and I'm pulsing the capsular fornix subincisional with BSS. In this case, it was nice and clean. And now I'm injecting some cohesive viscoelastic to fill the capsular bag. And then I'm using the sweep to polish underneath the rexus edge on the left side here. And on the right side here. This is a 3-piece lens, so I'm going to widen my incision with my diamond blade here. And I'm going to place the 3-piece intraocular lens into the capsular bag, pointing the bevel to the left, allowing the leading haptic to come out flat, pointing towards the left, going into the capsular bag, rotating my hand counterclockwise 90 degrees, which allows the optic to come out in the correct position, flat, leaving the trailing haptic out, and then dialing it in with the Maltzman. So I'm going to go in, activate irrigation, go underneath the lens, remove all the viscoelastic from within the bag. And then in the anterior chamber, polishing underneath the rexus edge a little bit here first. Switching to visco mode, remove all the viscoelastic from the anterior chamber. I'm just switching to polish mode as I try to dial the haptics here. And then I hydrate my incisions. So again, this patient had very wide excursions as he was breathing. It felt like I was doing cataract surgery on a boat. This rhythmic side-to-side movement. And so you saw how I was able to handle the case, doing the best I can with each of the steps. In the beginning, because most of the steps are one-handed, you are at the mercy of the patient's movement. But thankfully, once 2 instruments were in, we had better control of the eye, and the patient did well. So I hope this was helpful to you, and I thank you for your attention.